And now I'm thrilled to introduce the Institute for Experiential AI's Executive Director Usama Fayyad, who has an impressive background as a leader in AI and data science. Usama is the chairman and founder of Open Insights and served as the chief data officer at Barclays Bank and Yahoo. Usama will be speaking with Larry Brilliant, diving into AI and medical care. Usama, the floor is yours.
Thank you, Carmen. Of course, Carmen failed to mention that I'm also faculty at the Khoury College of Computer Science. I'm representing the poor computer scientists at this conference. But I have a bigger job here that's more interesting and exciting. I don't want to spend too much of the precious time, especially that we're falling behind, on introducing our guest. I really want you to go and read about him on the internet when you have time. He is, in my opinion, one of the most outstanding individuals I ever had the pleasure of having many, many deep discussions with. I think it's all due to the fact that he got all his degrees at the University of Michigan, like myself. But he humbly describes, he refers to it, I just was at the right place in the right time, which is BS if you ask me. You make your own destiny, and I think through our fireside chat, maybe you'll discover more about Larry, get a chance to go read about him, and read his book that he always I've read it like once in a scan. Now I have to go read it carefully because he keeps catching me saying, oh, you didn't get that, you didn't get that. It's called Sometimes Brilliant, so appropriately so. Larry, please come up. Want to sit down, or do you
No, yeah, I'm just going to grab this.
Okay. All right, I'll grab.
Are you going to be here?
Fine, I'll be here. You want to be here?
Yeah, I'm next to you. Thank you. Nice group of people.
Yeah, actually, the room was sold out. We were turning away many, many people, but of course, nobody starts this early. All right, so let me start out by saying one of the amazing accomplishments of Larry, and one of many, and by the way, his most recent gig is he's doing a new startup where we've partnered together as the Institute of Experiential AI and the AI plus Life Sciences group to help kind of build parts of it in a very close partnership. But one of the key distinctions here is Larry's involvement in the extinction of smallpox. I'm going to ask him a couple of questions on that to get us started here. But let me first ask you, Larry, how did you get involved in this smallpox pursuit to begin with?
First of all, it's really wonderful to be here. And we love working with the Institute. You guys have been more than partners in the building of this company called Evity. So I think if you look back on your own life and you ask yourself, how many of the most important things that happened to you because of planning, 5-year planning? How many happened to you because you were a creature of your time? Because the people that you met by accident at an event, at a party, through a friend that you read about and followed, they turned out to be the turning points, the hinges of the history of your life. Think about 5 of those. You don't have to be Forrest Gump. Just think about the people that you met that changed your life. So I'm a creature of the 60s. I followed the usual career path of a doctor in the 60s. So I'm from Michigan. I went to the University of Michigan. I did my medical school at Wayne in Detroit. Then I met Martin Luther King when I was 17. And I spent days with him, marched with him. It changed my life. Everything that I thought I knew about the world changed because of meeting Dr. King and ultimately getting arrested with him. But where we were arrested, there were so many of us that the police had to put a special fence around a group, and there were people called the Peter, Paul, and Mary. There were rock musicians with us, and I got to hear Dr. Martin Luther King sing Amazing Grace. I think I'd have gone to prison for that experience. But I did follow my course in the 60s. I became a civil rights specialist working for the federal government for the Office of Equal Health Opportunity in the LBJ administration. And then I went out to California for my internship. I was going to become a surgeon. I completed my internship. I was about to do a surgical residency. And a group of Native Americans took over Alcatraz Island, and a woman there who was 9 months pregnant wanted to have her baby on Indian-held land. No doctor was willing to go out there. So, of course, I did. And I lived with the Indians for 6 months, and I delivered a baby. I helped her deliver her baby. When I came back, there was a lot of media. I wound up on the Huntley Brinkley Show. Young people won't know what that is. And then I got a call from Warner Brothers, would I like to play a young doctor in a Hollywood movie about hippies, like the Grateful Dead and the Jefferson Airplane? So, of course, my wife and I said yes. We ditched the residency. We got a hippie bus. We left from San Francisco, and 2 years later, we wound up in Kathmandu. We lived in Iran, Iraq, Pakistan, India. During that period of time, I got to see more cultures and languages than most Americans. You may not know this, but 80% of the freshman congressmen from Mississippi and Alabama did not have a passport when they were elected to Congress. My perspective changed. I wound up living in a Himalayan monastery where we studied Buddhism and Hinduism and Islam and Christianity and Judaism. And one day, my teacher, named Curly Baba, kicked me out of the ashram. This is the usual career path in the 60s, I want you to know. Everything you read about the 60s is true. Not. He said to me one day, he said, "You're a doctor." I'd almost forgotten. He said, "You have to go down at WHO and you have to work for the smallpox eradication program because smallpox will be eradicated." He didn't speak English. We had to translate from the Pahari language that he spoke. How he knew that to the day I die will be one of the most enduring mysteries of my life. How could he even known about smallpox? And of course, when I go down to WHO, they kicked me out because I was wearing ashram clothes. He sent me back. I made 15 trips. Each trip was about 17 hours. And one day I walked into WHO, and for the first time in all these trips, there was an American there. I hadn't seen a single American. This is the Ciro office building. I'll show you the building if I could have that first slide. Oh. So this is the WHO office in New Delhi. I met some of the most important people in my life in this building. The first was D.A. Henderson, who became the Dean of Johns Hopkins. He was the global leader of smallpox eradication. And when I walked in, he said, "Are you American? Who are you?" I said, "I'm a doctor. I've been living in the Himalayas in an ashram with my guru who told me to come here because I was going to work for WHO because smallpox was going to be eradicated because this was God's will as a gift to humanity to lift one form of suffering from them." He said, "What did you just say?" He said, "We don't have a smallpox program. Mrs. Gandhi doesn't think smallpox is a priority. But thank you for coming to visit." He said, "While you're here, just for the record, why don't I interview you? If ever there's a smallpox program, we'll think about you." And he wrote in his report, "We're never going to hire this guy. He doesn't look like a doctor." Years later, when the smallpox program began, I got a call from WHO to come back. They had created a job category low enough that they could hire me. I was hired because I spoke English, I spoke Hindi, and I could type. I think I worked for WHO for 6 months before they remembered that I was a doctor. And then someone named Bill Fayyad, who became the head of CDC and became my mentor, and for the next 3 years taught me epidemiology, took me to the field and showed me my first case of smallpox. I have to tell you that smallpox was the worst disease in human history. Now, everybody's got their favorite worst disease. I don't want to have that competition. But in the 20th century, which was only 25 years ago, in the 20th century, from 1900 to 1980, smallpox killed 500 million people. Throughout history, beginning with Pharaoh Ramses V, where we have evidence from a biopsy taken of his mummy, smallpox killed people all over the world, tens of billions of people. The number of years of life lost to smallpox exceeds that of almost any other disease. And it's a horrible disease. You know, we're looking at COVID, we're thinking about a death rate of 1 in 1,000, 1 in 100. Smallpox killed 35% of people. It had a particularly cruel disposition to infect women who were pregnant, 100% fatality in women who were pregnant who got smallpox. So the smallpox program was not going very well. It was the middle of the Cold War. Russians and Americans had 20,000 nuclear missiles pointed at each other. But we managed to find a way to work together to build a program that worked in 35 countries. The last 5 cases were all in Southeast Asia: Nepal, India, Bangladesh, Pakistan, Sri Lanka.
Do you have slides on this?
I do. I'm going to come back to that in a second.
All right.
But I want to tell you about this building, because while I was working in smallpox, one day the woman, Mrs. Edna Boyer at the front desk, called me up and said, "Larry, there's somebody here who says he wants to see you." Larry, he's a dirty hippie. He's barefoot. His head is shaven. He reminds me of you when you first came here. And that's how I met Steve Jobs. Steve was 19 when we met. And that will help you to see the schizophrenia or multiple personality that I've developed over the years to be a techie and a physician. I'll tell you more about smallpox.
Big button. Yeah.
I've already told you about this.
Yes.
I will tell you that when I joined the program, the only way that we could deal with smallpox was through mass vaccination. And mass vaccination in densely populated countries like India just doesn't work, because you can't vaccinate 100% of people. And if you did, that year there'd be 20, 30 million new babies. You'd have to go back again. And smallpox continued to perpetuate itself throughout the Indian subcontinent. Bill Fayyad came up with a strategy called search and surveillance. It became known as ring vaccination. We had new tools. We had freeze-dried lyophilized vaccine. We had bifurcated needles. We were able to turn everybody, every farmer and every village worker, into a vaccinator. We found every single case of smallpox in the world at the same time and built a ring of immunity around them. I was 27 when I had 150,000 people working for me in the Indian program. We visited every house in India every month for 20 months. We made 2 billion house calls. I was just at the Mayo Clinic, which I love. They haven't made 2 billion house calls, I don't think. Maybe they have, I don't know. But it was an incredible army. And that's the recognition card. That's my wife and I when we were looking for smallpox all over India. You'd show a picture of a child with smallpox. That photograph was reproduced several billion times. And we'd say, "Have you seen anything like this?" And then we would vaccinate people around it in a circle. I think we went over this picture here. So this is a boy named Muhammad Ali, not the boxer. He was from Pakistan, and a CDC epidemiologist was there and took pictures of him throughout his disease. That's a mild case of smallpox. I dare not show you some of the awful pictures of smallpox. We declared it eradicated in 1980. But to do that, we had to go back to every country in the world and certify that there was no smallpox. That itself was a huge process that took 2 years. I just want to leave you with this, as far as talking about smallpox. I want you to be inspired about what a group of fanatic, crazy people can do when they're battling against something as horrible as that. I ask myself why we can't do that for climate change. I ask myself why we can't finish the job with polio eradication. But your generation should look to those successes and not feel hopeless. And don't feel it's impossible to have international cooperation amongst people who don't agree with each other. Because we showed that you could do it. That's the one thing I'd like you to carry away from smallpox.
All right. So as you can tell, it's very hard to control the path of an interview with this man. So he answered a few questions here, but I'm going to ask you a very super quick one and then lead into my second question. The super quick one is, so you think you were there when the last case of smallpox happened. Very quickly, Larry, how can you ascertain something like that? How do you know it's over?
So we had many false starts. We declared smallpox eradicated prematurely 4 or 5 times. Then something bad would happen. We found no cases of smallpox anywhere in India for 2 years. Then there was a report of 1 case of smallpox on Bola Island in Bangladesh. And in order to make people feel confident that this was not a false signal, I was sent to Bola Island and conducted a search of 3.5 million people surrounding the area of the case. It took us about 3 months to do that. We didn't find any other cases. We didn't find any other rumors. We then instituted a reward of $1,000, which was a lifetime of money for people there. We got over 5 million reports. We took specimens from all of them. We sent them to WHO and checked for virology. 95% of them were chickenpox, some were scabies, some were Stevens-Johnson syndrome. None were smallpox. 2 years passed with that reward. Every single time we did scar surveys, and we satisfied ourselves that there was no more smallpox. Her name was Rahima Banu. She was the last case of variola major in nature, and when the scabs dropped from her face, an unbroken chain of transmission going back 5,000 years at least ended. I was there, and when I saw it, I cried, as you would have done if you thought about what had happened in the context of history.
Yeah, witnessing the extinction of an evil virus. We don't have time to cover this, but there's a whole story after the fact about countries and nation states hoarding the virus, but we won't go into that right now. It's a report that got recently declassified by the US. So after the smallpox, what did you do in health data analytics? There was polio, there was the blindness survey in Nepal, and then maybe focus more, because we're running out of time, on what was Google flu trends.
It's great to see Dr. Shrestha here. After we had eradicated smallpox, the group who had worked together wanted to do something else again. And we thought about diarrheal diseases in babies, and in the end we decided we'd work on blindness. And we thought if we picked the hardest country in the world to work in, and we could succeed by having a random sample survey and do it right, an epidemiological survey, we chose Nepal because it was the hardest place in the world, we thought, to get helicopters and to do literally a stochastic sample. We expected to find glaucoma, trachoma, xerophthalmia. We found that 65% of the blindness in Nepal was due to cataract. And the SEVA Foundation that my wife and I started has now given back sight to 10 million blind people and treated 60 million people in 15 countries for blinding eye conditions. The people who eradicated smallpox went on to start the polio eradication program, the guinea worm eradication program, the expanded program, and that fellowship still exists. We still have a listserv. I was 25 years younger than anyone else in the program, So a lot of those folks have passed on now, but that's a great generation for you guys to look at and be proud of, I think, public health workers.
Google flu trends?
Google flu trends. So I got hired at Google. I was vice president, and I ran Google.org.
And a buddy of the founders, by the way.
And
Let's not go there.
I reported to Sergey, which is experience. I had started some tech companies and taken them public, and so when they brought me in, they were bringing in a doctor who was a techie. We decided that we could use the Google database, and if we could get 5 million computers to simultaneously run, 50,000 multiple logistic regressions, and we took every single keystroke ever entered into Google in its history, and we then did a reverse Y hat sub H and looked at 50 terms that could predict where the next case of flu would be, we would be able to match or exceed the speed with which CDC reported flu. We built Google Flu Trends. We beat CDC's reports by over 2 weeks with 100% accuracy for 2 years. The example shows that large data, big data, properly done, can have enormous public health consequences. Then my friend and I, who had started that, left Google, and the truth data on which it was based, the gold standard, CDC's data, was not kept up to date. And you can only cantilever a model a certain distance. This is a lesson for all of us in AI. You can only canter a lever, a model, beyond the truth data, beyond the ground truth, a certain level. And when you stop replenishing it, then the model begins to fail. And Google Flu Trends went from being the beginning of the field of digital health to being an example of why you can't trust a big company. I think that's the wrong inference, but it is the predominant inference. So,
You know, Larry in passing says, Y hat sub H. This is basically maximum likelihood hypothesis given a few billion queries around checking on flu, right? Anyway, that's a whole other topic that we can have a whole talk about. Let me jump into the future, hopefully, right now. So you talk about epidemiology of health span. How could health span be an epidemic?
So epidemiology is not the science of epidemics. It is the science of the distribution, determinants, deterrence, and effects of disease or conditions in defined populations. A lot of D's there. So it's a science. It's the use of large data in order to understand how to control an epidemic. That's how it began. It began with dot maps that John Snow did against cholera. It is now a very sophisticated science, and epidemiological modeling is very far of the kind of epidemiology we did on the ground in India at that time. So the epidemiology of health span is really a study of what's the distribution, determinants, and deterrence of years of healthy life in human populations. We have many.
So maybe for the audience sake, let's define health span versus lifespan.
Yeah.
And maybe you have some slides here.
I do. You're very helpful. I appreciate it. Touch the big button, he said. So Peter Attia drew this, if you've read his book, Outlive. And this is his way of showing the difference between longevity and health span. You see that area that's cross-hatched in there? That is called euphemistically the health span lifespan gap. What it really is sick span. You have youth, you have years of healthy life, health span, and then people are sick. And then you have the end of your life. That period of time, while longevity has been increasing, a friend of mine, Stephen Johnson, and I did a PBS special called An Extra Life. Over the last 100 years, life expectancy has doubled in the United States. That longevity has not been paired with an increase in health span, pro rata. In fact, today, Americans live a higher proportion of their life in sick span than ever in history. You all know this because you've got parents and grandparents. You watch siblings. you know that that period of time that you are not healthy is increasing. And I think I have a slide on that as well. So if you look at health span, and you can define health span as QALYs and DALYs and HALYs and all these quantitative measures the actuarials have. But we all know what it is, I think. But if you can see that it's gone from 10.8 years in 1990 to 12.7, it's really gone from something like 6 or 7 years before, because the causes of disease have changed so dramatically. Look at the causes of death in 1900. Everything below heart disease is an infectious disease. In fact, at one point in time, 9 out of the 10 leading causes of death were infectious diseases in the United States. The transition, thank you. The transition from acute diseases of short incubation period and short duration to diseases of long incubation period, multifactorial duration. Epidemiologists have these quaint terms called etiological fraction, attributable risk percentage. But look at the change. These chronic diseases, which are multifactorial, they're not easy to just say what causes each of them, but they are how we die now in developed countries. That change has led to a high period of time at the end of life that we live in a chronic disease situation.
And that has some interesting economic consequences that people don't think about. So let's jump from epidemiology to economics for a few minutes, and then I want to go back to a current topic. So what's the economic?
Is he this tough on you, Sam?
Yes. I'm tougher on most people, by the way, but I can't. With this guy, I can't. I love him too much.
So, I like to say that longevity is a double-edged sword, because we all want our friends, ourselves, our loved ones to live as long as possible. But the aging of the population is an issue. By the way, Foreign Affairs has a special today on the aging of the population and the decline in population that has begun about 10 years ago globally. Everything against what we learned over the past 20 years. So we talk about two kinds of transitions. The epidemiological transition, which I just described, from acute diseases to chronic diseases. But the demographic transition is even more important. A world in which there are many deaths, many births, and a high growth rate, to a world in which there are few deaths, few births, slower growth rate. That's the era that we're in right now. That demographic transition takes the healthy economic demographic pyramid, in which you have something called the dependency ratio, this cute term where the people between the age of 15 and 65 are considered to be the wage earners. Why 65? Because Bismarck set that in 1900 as the year of retirement.
Let's not go there.
But let's not go talk. We're not going to talk about Bismarck. So that period of time in the demographics idea, those are the wage earners. Everybody over 65 and under 15 are dependents. When that ratio is 1 to 1 or 1 to 2.5, you have a healthy economy. But Japan is almost 2. The demographic triangle in Japan looks like a rectangle, and the American demographic triangle is beginning to look like a rectangle too. These are the things that encouraged me to start Evity. When I looked at that period of time and I said that we know how to help people to live longer, healthier lives. We just don't know how to translate the experience we've learned in these two great bits of magic that are going on. Arthur Clarke said, any sufficiently advanced technology is indistinguishable from magic. We have two of them right now. AI is indistinguishable from magic. Medical science, go to the Mayo Clinic where I just was. Medical science is advanced so much it's indistinguishable from magic. I thought, can we put those two things together in a way to narrow that six-span, increased years of healthy life for everybody in the world, regardless of their income, regardless of race or religion?
And that brings us to my passion, AI. So first of all, we're working with Evity on building the AI and the generative AI underneath it, with a big distinction that we'll talk about in a second. But first of all, does AI work? Does it help? Or does it fail miserably?
Both. right? Who has not had an experience with an AI hallucinating? Really? Nobody? Come on. Somebody has had no experience. So recently I queried ChatGPT 4, which I love in many ways, and I said, I'm interested in VO2 max, the maximum amount of oxygen that you can consume. I'm interested in the gold standard where you put a mask on and you run on a treadmill till you pass out. People don't come back for that the second time. I don't know why. What are the surrogates for that? What about the 6-minute walk for people over 65, the 12-minute run for people under 35? And I asked ChatGPT, are those good proxies? It said yes. I said, well, do they go in concordance? Are they divergent? Are they always good? He said, there's a great article about that. What's the name of the article? It's called A Peer-Reviewed Study of the Use of Field-Based Tests for VO2 max against the lab-based gold standard. I said, great. Who are the authors? It showed me. Where's the abstract? I read it. It was great. I said, where's the article? It showed me. None of that exists. The article doesn't exist. The authors don't exist. The citations don't exist.
But wait,
the journal
doesn't exist. Yeah.
And if I hadn't had my phone and photographed the output, you wouldn't believe it. I have that experience often. I'm trained to try to make AIs hallucinate. Because in medicine, we can't have it. We are the most risk-averse profession. We are not allowed to kill one person in order to save 100. We have this primo non nocere, first do no harm. What works for ChatGPT and generative AIs in so many parts of the world will not work in medicine as they are today.
So what's the right approach?
Experts in the loop.
All right. What does that mean?
It means keeping human experts in the loop. It means paying for experts in neurology, cardiology, orthopedic surgery, burden of proof calculation, stochastic processing, genomics, so that those experts go way beyond RAG and go into a form of expert-driven input and curation and keeping that expert in the loop throughout the entire life cycle of the data. And then making, as we're doing with you, creating decision support systems that help clinicians make better decisions, that help physical therapists make better decisions, that help you make better decisions.
So I'm going to do one question and then turn it over, even though I have a few exciting questions here, but maybe we'll do them on a podcast. I'm going to do one last question, then turn it over to questions in the audience. So if you have a question, not a statement, prepare it and be ready to ask. Now, the FDA has made the news, and by the way, human in the loop, experiential AI is our short form statement for AI with the human in the loop. But anyway, that's a different story. The FDA made the news on encouraging physicians to leverage AI. And then they backed off from the responsibility side of it. So what can you tell us about this?
Well, this is the Chairman Powell saying, Cahill saying, if hospitals invest in algorithms without understanding what they're trained in, and there is a mistake, an accident, he said, the FDA will not bail you out. We're at this moment of these two great technologies. We have to find a way to use the power of AI without the negative externalities. And that's what I think he's saying. I hope that's what we're building.
Okay, any questions? Well, we have two, one in the back, one over here. So do we have a mic? Yes, no? Do I ask a question? Oh, there's a... Thank you.
Thank you so much, Doctor. I'm a registered nurse, actually a former Bouvet student myself, and I've been working in big data since 2017. I've been working at various startups, and often I'm the only clinician in the room sitting back and listening. I've heard folks say, clinicians slow us down. We don't want to involve them. I sort of hide the fact that I'm a registered nurse. Do you have any advice for me on what to say when folks say, clinicians slow us down, physicians, nurses, we don't want them involved?
Well, It of course depends on who the clinician is. I'm sure that some clinicians speed you up and don't slow you down, and some slow you down. It's like you want to have everybody involved in the conversation who can make a positive impact on the patient's welfare. You want to be patient-centric. You want to make the decisions that help the health seeker or the patient. We think that is best by pairing a patient with a clinician. It doesn't have to be an MD. There's 1.2 million MDs. There's 10 times as many other people who have NPI numbers. We just look at people who have NPI numbers, the national prescriber number. But it's always better to have someone, a human expert, and an AI in your pocket and a health seeker together. That's what we try to do. But I'm sorry about that experience. But we should all really appreciate nurses more. I think that's the takeaway.
A nurse lifting big data. I love it. You're my new hero. There was another question quickly. Yeah, you got to come to the mic, please. And while you're walking, I'm going to ask my question. No, I'm kidding. Go ahead.
Thank you so much for sharing. My name is Ling Shen. I'm the founder and CEO of the Tech Connect Venture Studio for Precision Health. So thank you so much for sharing your earlier, experience of how you speak multiple languages and that how work to your advantage to communicate with a different kind of stakeholder. So we also touched the point on the AI, and I'm very curious. You say it's not really hard to do the global collaborative efforts to contribute, to the public health and the data side. What do you view is the biggest challenge these days, and what would be the opportunities to form the global collaborative efforts in the future, especially, among the younger generation with your generations of the wealth?
So there's a very long answer that he won't let me give. but it has to do with centrifugal and centripetal forces. I think after the Second World War, the globe population was ready to bring us together again and to not let the horrors of the Second World War get repeated. Those institutions, the alphabet soup, WHO, FAO, UNICEF, UNESCO, the Security Council, they kept the world safe and allowed for those kinds of collaborations for 70 years. They're long in the tooth now, and the world is being pulled apart, in my mind, by populism. So it's very difficult now. But peer-to-peer, and you have this thing called the internet. And social media, with all of its toxins, there are places in the social media that are wholesome, they're intended to do good in the world. Seek them out. Because when you have that kind of a relationship, it's a global relationship. I'll just say one story about my friend Bill Foege. He said the one good thing about COVID is it got us using Zoom and doing virtual meetings. We'll never have an excuse to not bring an African doctor or a doctor from Latin America to our meetings in Boston anymore, because we can have virtual meetings, hybrid meetings. That's the global commons that we can build. You can build that. We couldn't have built it in my day. So we had to go there ourselves. You can fly everywhere faster than we could go.
All right. We are basically at time, although we started a few minutes late. So I'm going to claim them right now and ask my last question. Oh, Beth has a question. My dean has a question.
I'm pulling rank. Beth Minot, Dean of the Corey College of Computer Sciences.
Hi, Dean.
Very good to see you. Love this discussion. We're going to keep it going all day. One aspect of the chart you showed with respect to cause of death is moving from acute to chronic disease. How can AI be the lever to reform healthcare to move out of care in the institution and care in the home and care throughout all of life?
Well, first, let's agree that's the noble objective. I don't think we know the causes of death for 50% of deaths in the world today. The death certificate is ambiguous. In the United States, physicians are nudged to pick a cause of death that has a reimbursement plan next to it. Many deaths are caused by multiple things. If it's a multiple choice answer, you know that people are going to pick other answers perhaps than the one you would have liked them to make. So it's not just causes of death, I think. It's causes of health. It's how do we promote the things that allow people to live longer and healthier lives. There's a lot of fish oil in the world that I live in the longevity world. There's a lot of snake oil. Separating fish oil from snake oil is the business that we have to be in if we're trying to increase years of healthy living. But we can do it. And AIs can help us immensely to do it if we train them, we tame them, we use them for what they're fit for purpose. But moving out from the sick care world, we probably spend, I think we passed 20% of our global GDP on healthcare in the United States in March of this year. Probably 50% of that is spent in the last 10 years of life. Maybe it's more than that now. That we need to find a way to not let that bankrupt the country. I worry about COVID, long COVID bankrupting Medicare, for example, because of the long tail of it becoming a chronic disease. So we need to find ways to make people have the availability of the information, the clinical support, the team around them, and the fast-breaking, wonderful changes in medical science that tomorrow will give you a new immunotherapy. Think of the world before Cartigen. The physicians in here know what I'm talking about. When chemotherapy made you almost as sick as the disease. We're going to be exiting some of those worlds because of the amazing transformation of medical science. Use that in a way to help it be delivered outside the house, outside the hospital.
So before we thank our guest and wrap this up, I will ask you a very quick last question with a very quick answer, hopefully, and maybe a concluding slide. Look, we all know that today the only working AI is completely data-driven because of machine learning. However, the big AI companies know this, and I say this in public all the time. They know that they need the human in the loop. They need intervention. They need a lot of data curation. And these two areas, they don't talk about at all. Whereas it actually is one of the costliest parts of them doing their business and launching these models. And often these models make, you call it hallucination, you bought the Google Kool-Aid, we like to call it errors. But
I call it bullshit, but I can't say that in a group like this.
Okay, all right. So what are your thoughts on data curation? And let that be our very brief conclusion. And you have a slide.
Oh, this will confuse everybody, but I'll do it. So this is what we're building, where we have curators in the loop at every stage of the delivery of health information. No photographs, please. No, I'm kidding. But we build teams. So I go to a named cardiologist, a good friend of mine, he's world famous, and I say, will you be my curator in heart disease? Of course, he says, you can use my name, but I'm not going to do shit. So I say, what if I build a team around you? So you have to build a team of curators, and you have to build an easy button for curation. Otherwise, people are not going to stay in the loop. And you bring in people from cardiology and neurology and physiology and neurodegenerative diseases, metabolic diseases, and you make them part of the training program. And you do it not just in the beginning, not in the reinforcement with human feedback. You go way beyond that. So it's what you don't have in there. If we build a novel hybrid human AI model that has a mere 8 billion parameters, we look like pausers to compare ourselves to ChatGPT's got 176 trillion parameters. But at some point, many of those parameters do less good than harm. Your medical model doesn't need to know anything about Trump or baseball scores. It knows everything about virology and everything about burden of proof. So building systems like that, I think, is the future. We hope to be a part of it.
All right, with that theme, please join me in thanking our guest, Dr. Larry Brilliant, for a brilliant interview.
And please join me in thanking my friend Usama Fayyad and Sam Scarpino and the wonderful Institute for Experiential AI.